Hello, everyone. Welcome. Welcome to our Sun Training 101. We are very excited to have you here today with our speaker, but we want to do some housekeeping. For the best experience today, connect your computer to a power outlet. We don't want you to have a power shortage. Close unnecessary windows on your browsers, just so that way it won't cut in and out. Use the chat for your questions and please make sure that it's addressed to everyone, to all panelists and attendees. Sometimes it's just to the panelists. So we want everybody to see your question because they probably have the same question. And closed captions will be available throughout the session. So you can read along as well. So let's get started. Who's here today? Type in the chat where you're from. Sun Training 101, leading change, right, in the hospital culture. I know this has been a challenge for many, many suns, and it's still a challenge. So without further ado, we're going to jump right into our training this time. It's only been 11:01, so I'll give it another minute so people can hop on board. This is brought to you by the California Bridge and Public Health Institute. And this is our agenda for today. We are welcoming you now and so excited to have you here. Charles Hawthorne, if those who have not heard him, he is a phenomenal speaker. I can't wait to get started. We will have a question and answer at the end, or type it in the chat. And then we're going to talk about promoting your own program in your own hospital and the takeaways. Okay. Our objectives today are identifying strategies, and you can read them, the list here, to create a culture of harm reduction in your hospital. This is really probably the most important. Identify ethical and moral dilemmas of harm reduction. Describe destigmatizing language when interacting with patients. This is huge because you guys are the role models. And identify concepts of racial justice and equity for substance use disorder patients, something you're doing every day. And verbalize definition of cultural competence, right? Just within our changing the culture, you will know what that means. So without further ado, I have, and those who have not heard him, you're in for a treat. This is probably one of the best trainings that we offer. You're going to have tons of great techniques after this training. Charles Hawthorne is the capacity building manager for the National Harm Reduction Coalition. Their role includes leading harm reduction training work for the state of California, as well as supporting harm reduction programs with technical assistance. That's why he's here with us today. Charles received their BS in biochemistry from Purdue University and is currently pursuing their master's in public health from Johns Hopkins University as a Bloomberg American Health Initiative Fellow. And that is quite an honor. So it is my pleasure to introduce Charles Hawthorne.
Thank you so much, Sherry. You're always just flattering me. I really appreciate it. Hello, everyone. To folks who I've met before, nice to see you again. To new people, it's nice to see you virtually. My name is Charles Hawthorne. Like Sherry said, I work with the National Harm Reduction Coalition, and a big piece of my role is supporting y'all. So a lot of the work that I do is working directly with the Sun mentors, working with Suns, as well as working with providers in your hospitals, just to figure out how do you best incorporate harm reduction into the work that you're doing. And so today we're going to talk a little bit about culture. We're going to talk about how do things work? What does culture look like in your hospitals? And what I want to just kind of the format of this is on the first half of my training, I'm going to kind of walk through some definitions together. We're going to talk about some things. I want to hear from y'all. So feel free, like when I ask questions, please type your answers into the chat. I'll read them out loud. We can kind of discuss them and bat them around. And then on the second half of the training, some of the Sun mentors are actually going to take a couple different tips that we came up with. We had a conversation. What we talked about, what is the really important things that you need to do to start changing the culture of your hospital? And they're each going to walk through those, give you a little bit of a story about what that looks like, and give you some tips on how to do that. All right, so yeah, let's go ahead and jump right in. Awesome, thank you. So first, just to kind of ground us, I always like to talk about what is harm reduction. And so when we are talking about harm reduction within our work within the California Bridge program, as well as working directly with harm reduction programs, the definition that we usually use is harm reduction utilizes a spectrum of strategies to reduce the negative consequences associated with drug use, sex work, and other behaviors that people engage in. And these usually fall into a few different categories. We talk about safer techniques, managed use, and abstinence. So when I say something like safer techniques, what's an example of safer techniques that people might use to reduce the negative consequences associated with something like drug use or sex work? Not using alone. Thank you, Megan. So yeah, so even if you're using the same amount of a drug, when you have somebody that's with you where in case you go out, in case you overdose, maybe you just have a bad time, you have somebody who can keep an eye on you, who can call support if they need it and help keep you safe. Sophia and Melissa said using sterile syringes or needle exchange. Yep, absolutely. So using a new sterile needle to prevent risk of injury or infectious disease. Reducing your use or maybe changing the way you use, maybe switching from injecting to smoking to give your veins a rest. Having Narcan. Thank you, Melissa. Thank you, Sarah. A few different people said Narcan too. Yeah, as well as, and then, Rebecca as well. So having Narcan, which is that overdose reversal medication. So if somebody's using opioids, you can use, and they go out, they overdose, you can use Narcan and other overdose prevention techniques as a way to bring them back. Christina said condoms. Yeah. So when it comes to sex, condoms is a huge piece as well. Condoms are one of the most effective tools that we have to reduce the transmission of STIs. And keep us safe when we're having sex. Getting all test strips. So when some people are sending messages, what you can actually do is change your to all panelists and attendees. That way everybody can read them along with me while you're go ahead and posting them in. Because all of us are getting some of them, but everybody can't get them. So yes, go ahead and change your message to all panelists and attendees so that folks can see it. Thank you for that, Tiffany. And then Kelly had added providing cookers and work kits and stuff like that. So when people are injecting drugs, there's lots of tools that you need to stay safe. And so providing those tools is helpful as well. And then next we have managed use. So when we talk about managed use, what are some ways that people can reduce their harm through managing the ways that they engage with behaviors? Yeah. And then also other folks, all the Sun mentors and stuff are welcome to hop in as well. Megan said sterile needle exchange. So that would be a safer technique. However, if what you said is, I'm only going to inject if I have access to new sterile needles, that's a strategy for managing the way you engage with use. You're managing your use so that you're only using when you are feeling like you're optimally protecting yourself. Yeah, so what are some strategies that people use to manage their use in order to reduce their harm? Scott said setting clear boundaries on how much to use. Absolutely. So saying I'm going to use within these hours, I'm only going to use on these days. Tiffany said medication assisted treatment. Absolutely. So maybe what you recognize is I can't completely let this drug go, but what I can do is maybe incorporate something like methadone or buprenorphine in order to reduce my craving. So maybe I'm only using that, or I'm using that and way less of my drug. Knowing when your use becomes disruptive and using less if possible or seeking out MAT. I love the way that you phrase that. Is when does your use start interfering with the things that you want to do? When is it getting in the way of accomplishing the things that you want to accomplish? And so when you're recognizing that, that's a piece of managed use and saying, now I'm going to change the way that I'm using in order to stay as safe as possible. All right. And then last, we have abstinence. So a lot of times when we talk about harm reduction, we kind of think about, people will sometimes say to me, is like, well, you're for harm reduction or you're for abstinence. And I don't really agree with that, which is why abstinence is on my slide. So how does abstinence fit into harm reduction? What makes abstinence a harm reduction strategy? How can practicing abstinence reduce your harm? Yeah, if you're not using it all, then you're probably not dealing with the harms that come from drug use. Also, when it's your own decision to stop. Yeah, so thank you, Scott. Thank you, Anne. And that's the decision you make, where it's like, this is what's going to be best for me in this situation, is not using this drug. Melissa said, we have a few different people. Yeah, Melissa said abstinence is ultimate harm reduction, but it's not necessarily realistic for everybody. So we also recognize that there's some barriers to abstinence for some people. And that's what harm reduction allows us to recognize, is that people move up and down this based on their capacity to handle different things. Yeah, and if you're not using, you're no longer engaging in more dangerous aspects of things. Maybe if what you're looking for is sobriety, practicing abstinence from some substances or all substances begins to get you on that path towards sobriety, if that's your goal. Yeah, it could be seen as levels. So maybe if abstinence is essentially is going to be ultimately your goal, harm reduction can be a way for you to help get there. Or it is your way that you're practicing harm reduction. Maybe one day you're practicing harm reduction with safer techniques, and then one day you're practicing with managed use, and one day you're practicing harm reduction by not using. Dennis said progress, not perfection. Yeah. So within harm reduction, we recognize that it's about moving towards your goals. It's not always about saying that you have to be perfect. And that changes the way that we think about abstinence a lot. And Rebecca kind of touched on this as well. So knowing that relapse is okay, and knowing that the increased risk of overdose if relapse does occur. So you named kind of two things in there. So number one, we know that relapse happens. It's really common. It happens with all different types of diseases. It happens when people are taking heart medication. It happens with special diets for diabetes. People relapse all the time. But when it comes to drug relapses or substance use disorder relapses, there's a lot more stigma and shame attached to it. And then something else that Rebecca had named is when you are relapsing, there's an increased risk of overdose. If you go back to your same dose that you were using before you were abstinent, your tolerance has probably dropped, and that can put you at an increased risk for overdose. So there's a counseling piece in there of yes, you're abstinent, and if you do make that decision, make sure when you go back, you only use a little bit, because that's going to keep you safe. Being forgiving, learning new coping skills, abstinence from substances can help you stay away from other situations as well. So maybe your substance use is tied to other risks that are navigated. Absolutely. This is super great. Y'all know so much about this already. Can you hit the next slide, please? Awesome. So when we talk about culture, so we've kind of talked about what harm reduction looks like. So when you think about the culture towards drug use in your hospital, what are some examples of how that culture comes out? When you think about this is how people in my hospital think about drug use, this is how they treat people who use drugs, this is what the common way to navigate that is, what comes up? Get them in and out as soon as possible. It's we are not trying to deal with these people. So anytime, and maybe there's a lot of assumptions that's included in that. So we don't want these people here because they feel dangerous, because they're scary, because they're a waste of time. So there's a lot of things that are tied up in that. Sophia said a lot of stigma and labeling patients as addicts. There's a lot loaded in that of what people think. Judgmental. Oh, Tanya said, quote, the ER is not detox. So people have very specific feelings about how people are using the ER, especially in these situations. But we're trying to change that. I know you are, Melissa. there is a big stigma on addicts, and it's really challenging. A lot of judgment. Angela said we have real sick people here. So there's that perspective of people who are in the ED are just kind of wasting our time. Leanne also said they are seeking. So people are looking for drugs. That's the only reason they're here is because they want drugs. Those aren't the people who need our attention, frequent flyers, not there's I really want to also say Abby had said no responsibility for follow-up care. So as providers, maybe people around substance use don't feel like they're responsible for making sure that person continues to be healthy, continues to be well, continues to get the care that they need. It's not our responsibility. Somebody else can worry about that. Alicia said, yeah, I'm sure they're going to stick with this. So maybe like some sarcastic feelings or just like, yeah, they're just going to keep using drugs. Yeah. Yeah. And Tiffany said, why try to help them when they're going to leave here and go back to where got here in the first place? So it feels redundant. It feels pointless. Yeah, I think that there's a lot. And Tina said they do it to themselves. They won't change. So there's a lot of themes in here that are kind of coming out that I want to kind of name. Compassion fatigue. Zinnia said, like any other illness, that's good. That means you've probably been doing some work in your ED to get them there. And then there's like a lot of doubt around follow-up that Kelly and Ann both named. Zinnia, you seem like you got some good stuff going on in your spot. So like, I'm glad that they feel like they should offer follow-up and all those things. That's really where we should be going. So we also had this conversation with all of the Sun mentors, and we came up with a lot of the similar stuff that you're naming, which is good. That means that we have a pulse on what's going on. And we kind of narrowed it down to a few pieces. Could you hit the next slide, please? Yeah. So there's a few different things that we're naming. So right at the top, there's a lack of knowledge about drugs and people who use them. So when we talk about knowledge, there's that piece around like, how do drugs work? How do drugs function? Like one of the big things that we've been having a lot of conversations about is around like meth-induced psychosis and people feeling like people who use stimulants are huge troublemakers and always causing problems. And that's not really how drugs work. It's like, you don't just like use meth and go crazy. That's not really how substances work in general. A lot of people don't know that. There's a lot of assumptions. There's a lot of stigma. There's a lot of old like tales that people hear that don't really reflect the reality. And oftentimes they don't know a lot about that. They treat people who use drugs different than other patients. So that comes back to like what Tamara is saying in here, a lack of understanding addiction as a medical disease versus a moral failing. So when they look at people who use drugs, they're saying, oh, you are a problem. You made a bad decision and that's why you're here. And therefore, you're not really a sick person. You're just don't have willpower. You don't have this. And therefore, it changes the way that they provide care. It changes the way that they treat people. And a lot of times that means that worse care is coming people's way. And then down in the bottom right, we have lack of patience and time for appropriate care. So that's kind of like a couple different things. So that kind of names like on one side that when you're in the ED, you're moving super fast. You always have things to do. There's always somebody new coming in. There's always a different priority. And you have to help a lot of different people, which is like the nature of the beast, which I think that we can critique a lot how our medical system functions in general. But that's the way that things are in the ED. However, yeah, they work long hours, maybe feeling, and they're tired. And then also we have these perspectives that people brought up of like, we have real sick people here, or they're frequent flyers, or they're just going to be back here next week. And it's not our job to follow up, and all these things that come along with that. We don't have an opioid problem in our ED. That is, wow, that's kind of a crock of shit. I don't know if there's a single ED that doesn't have an opioid problem. And that's the problem, is like, there's a lot of people who say this is not our responsibility, and they would rather it stay not their responsibility than figure out how to appropriately manage it. Because oftentimes time feels like a limiting factor. And then we have this purple one on the bottom left, coercive treatment. as tough love care. So we have that thing of like what Tiffany's saying in here right now. It's like substance users are lazy. They're not trying. And therefore, if they're going to get care, they're going to get the care that we want them to get. So a lot of times that means forcing people into certain treatments. It means denying people medical care. I think when we talk about drug-seeking behavior, we could have that conversation all day. I have a lot to say about that. And I think the cliff notes I have of that is like our whole medical system is drug seeking. Everybody is taught to seek drugs. That's how we treat medical care. That's how we treat medical problems in the US is we treat them with drugs. And the instant that you use those drugs in a way that our system doesn't like, that's when it becomes a problem. Or you use drugs that people aren't making money off of, or you're using them in a way that looks bad. That's when people start having an issue. Yeah. So we have that tough love piece of like people just feel like they have to tell people how to get treated. And then oftentimes what happens is people don't want to get care. They leave, they check out early, they don't treat their doctors and providers well. Yeah, so much. And then a lot of that comes down to assumptions, blame, and judgment in the middle left. People make assumptions about people who use drugs. They blame them for the issues that they have, and they pass judgment. And that is really how the culture perpetuates itself. And when you have new doctors coming in who are taught those people aren't worth our time, who hear these messages about frequent flyers, who hear these messages about, why are you spending so much time in that patient? They're just going to be back next week. They're not going to actually stop. You want to do all this. And oftentimes when we are taught to think about drug use, and I think this is a way that doctors oftentimes set themselves up for failure, is you're not a hero. I think people want to be a hero. They want to save people who use drugs. And when they find that you can't save another person, it goes the other direction. People get really sad. Somebody earlier had said they feel inadequate as providers. They feel incapable. Can anybody kind of speak to that about like, what does it feel? I think that maybe when we were working with our son mentors, we had talked a little bit about providers not feeling capable of providing care. Has anybody had an experience with that, with working with a provider who just didn't feel capable of caring for a person who uses drugs? Yeah. My provider shared that sometimes she feels like a drug dealer. Wow. Could you say a little bit more about that, Tiffany? Yeah. Yeah. And yeah. And then Melissa added, there's no standard operating procedures for overdoses in the ER. That's wild to think about. When there isn't a plan, when we don't know how we're going to treat these things, of course people get confused. They feel inadequate. They don't know how to think through things. Ashley said, I felt intimidated for a long time when I would provide input and providers outright disregarded anything, which is such kind of this, when we're going to talk about that a little bit more later today with the Sun mentors, but absolutely. And yeah, so people feel disregarded. People treated more urgently, other people treated more urgently. A lack of understanding of harm reduction makes people feel like they're enabling. And then Tiffany said, because she's prescribing MAT, it's almost just like a Band-Aid, even though that is the service that people need sometimes when you're providing MAT. You're helping them get what they need to continue to function. But when people don't understand how harm reduction works, it makes them feel like a bad person. And they feel like maybe they're given one crutch for another. But sometimes what people need is a crutch. There's nothing wrong with a crutch. There's nothing wrong with people needing support. All right, could you hit the next slide? And so when we talk about culture of humility, a big piece of culture humility ties back to racial equity. It ties back to harm reduction. It ties back to understanding how to support queer people, how to support people who use drugs. Like all of that's really connected. And what that truly means to me is understanding that you are a lifelong learner. when you're working with people from different cultures. And when we say culture, we mean cultures of people with different experiences, like people who use drugs or people who are unhoused. We mean people of color and different cultural groups within that. And we are called to have culture of humility because we actually don't always know what we're talking about. We don't always know what people need. We can't speak for what makes people comfortable. Scott said perpetual student. Yeah, we should all be striving to be perpetual students because we should all be able to learn and grow and get better. The instant you stop growing, that's when you start dying. When you stop learning more, when you stop being able to engage with people in a different way and be told that you're wrong, things don't get better. You don't learn how to do your job better. So when we practice culture humility as sons, what that allows us to do is ensure that we are modeling that behavior, that we're connecting with our clients, and we're in modeling that behavior, we're showing our providers, this is how you engage with people. It's not about coming from a superiority place. It's not about telling people what it's to do. It's about meeting people at their level and allowing you to both teach them and for them to teach you. Because if they can't teach you, you can't teach them. That's how that exchange works. And Kelly said remaining teachable. We all have to remain teachable. And that means that we have to be open to critique. That means we have to be open to people telling us we're wrong. My mom did a lot of work around culture change and organizations when I was growing up. And one thing that she always used to tell me is sometimes people are going to give you feedback and you're not going to like the way that they give it to you. And it's going to be really good feedback. Sometimes feedback's going to come with a couple of cuss words in it. Sometimes feedback isn't always going to feel nice. Sometimes feedback's going to hurt your feelings. It's really hard. I'm like thinking about times where I've gotten feedback and I'm like, that didn't make me feel good. And what culture humility, the model of that tells us to do is like, and I'm a student, I can take feedback. Sometimes you get a C on a test because you didn't know what you were talking about. And the difference between maybe a punitive system where you get that C and you move on, as opposed to a righteous system, a system of equity is, all right, so let's talk about that. Let's talk about how I can be better and how I can improve. Because when we are able to stay in that space of making sure that we are also breaking through these cultures, because all the systems that make doctors like that and the ED, those are the same systems that are working on us. Those are the same things that we are needing to unpack. And sometimes we are going to need our clients, we're going to need our patients, our friends and our family to give us that feedback and each other. It helps us grow. It challenges your thought processes. It's kind of like when you put like a stake next to a plant. It gives it something to grow next to and change the way that it's shaped. And we're all trying to become the best that we can be. And that means that sometimes we have to get redirected a bit. So staying open to feedback, staying open to learning, not assuming you know it all are all really big pieces of this. And can you hit the next slide, please? And so when we talk about a stronger harm reduction culture in our hospitals, it's a mix of bringing together that culture of humility, the aspect of being a lifelong student, of understanding that we don't always know everything about the people who we are working with, and we can be students of them, we can take feedback, we can learn, we can grow. And we combine that with this perspective around behavior change, this perspective around drug use that recognizes that change is possible and we have to work with people, that people have so many different ways that they can reduce their harm other than just like stopping using drugs. Like understanding harm reduction allows us to see that like you're not a drug dealer for prescribing your patients buprenorphine, you're a good person. You're making sure that they can go out, they don't have to hustle for another drug. They don't have to, they're not at a higher overdose risk. They have all the tools they need to live a safe and happy life. And that's really what harm reduction gives us permission to do. And culture of humility gives us the perspective. Yeah, it's a shift in perception. It's exactly Tiffany. We want to be able to hear when people have feedback for us, when people want us to be better, because that's how we actually start seeing where the harm reduction aspects are coming up in their life. that's how we have those conversations with people. We can't talk to people about their risks and their harms if we're not able to meet them at their level and have a conversation with them at their level. All right, so we're going to go ahead and I'm going to turn it over to our Sun mentors. Could you hit the next slide, please? Perfect. And we're going to talk a little bit about how we do this work of changing hospital culture. So we're going to go ahead and start off with Rebecca. We're going to have 5 tips we're going to walk through. And I'm going to go ahead and turn it over. Let's turn my mic off.
Hey everyone. Like Charles was saying, I want to tell you a little tip about how showing is greater than telling, especially when it comes to our site staff members. So what I like to do is always elevate our patient participants and show the staff that I am there working for them. I'm serving them, right? I'm elevating them and that they have come to our site, either seeking help or maybe just wanting more safer use techniques during your consultation. And so elevating that person because they do feel internal shame and stigma for being there in the first place can really show your staff that people who use drugs and alcohol should not be treated as subhuman. I want to share 2 stories if I have time. So in regards to my nursing team, I work in a real small emergency department when we're in a rural area with limited beds. And I had this patient once for the bridge program. I had already talked to him. He was in just really, really severe withdrawal. And he was sitting in the waiting room with like 20 barf bags on him, just having a really, really terrible time, breaking down, crying. Everyone in the emergency room was just kind of like looking at him because he was having such a hard time. Other patients were. And so when I went out, I spoke to him. I said, hey, I know it's rough out here. I'm going to go and see if we have, a more private, comfortable area where you can sit. So I went to our team lead and said, yeah, I know we don't have any beds right now, but is there anything we can do for this patient he's having the hardest time with his withdrawals right now? And the team lead said, absolutely. And he went around and searched, and we found one of our treatment chairs, which is all comfy and cushy for him to sit in. We brought him water and juice while he waited for his dose. And the rest of the nursing staff took note and saw myself and my team lead just kind of running around. It only took 2 minutes, really, to find a place for this person to elevate that, they were there to get help, and they shouldn't be just left in the waiting room, given the cold shoulder. So that's my story about my nursing team, and they really caught on after that. That folks, they do need to be treated with equal dignity, no matter what they're in our emergency departments for. And my provider story is, and I do this to this day, because they'll have 20 patients after their triage time in my emergency department. And I'll go and notice that it's been an hour since the last buprenorphine administration. And I'll take our little COWS form and I'll do a COWS on the patient because they're still withdrawing. And I'll come back and say, hey, I just noticed that it's been an hour since last dose. I wanted to do a COWS for you. The patient's still complaining of this, exhibiting these signs. How do you feel about this patient? Do you think that they should get another dose? Are you moving towards discharge? And this kind of trains your clinician to zone in on your bridge patients and realize, oh, did I just leave them in the waiting room for 4 hours while I wait to discharge them? I have to be following up on them. And just like any other patient, right? They've got to and sure that patient getting adequate dosing while in the emergency department, and just being on top of that patient. And then I want to share one more provider story. I had a personal experience when I first started, and one of the doctors and PAs were joking in the charting room, and they said, oh, this guy's never going to change. He's not going to stop using heroin. I'm like, yeah, right. Just being so smug and disrespectful to this person. And I was in the charting room and I had to go up to them and expose myself, which is hard to do on the job. And I said, you know, you're not giving this person enough credit. Recovery can happen, and I'm living proof of that. I wouldn't be able to stand here and talk to you today if recovery wasn't possible. So just being as truthful and transparent as you can, and always advocating for your patients, showing them, showing your staff that you're there for them and they deserve excellent care, just like everybody else does. Thank you, everyone.
Angela Caldwell, are you ready?
I'm ready.
Number 2.
Hi, everybody. I'm going to talk about advocating for your patients, which actually Rebecca's story in regards to getting making sure that your patient's getting their next dose or whatever was kind of one of my starting points. Is the most simple way to advocate. What we do in our facility is when we have a patient come in and they are, we determine that they're ready to start on the buprenorphine. We make sure that we let the doctor know this patient, seems to be ready to start. Can you order that? And we stay there. We sometimes sit right next to the patient and wait right with them until they get that dose. Make sure that get them a warm blanket, get them whatever they need at that moment to make it more comfortable until they get that dose and start feeling better. But oftentimes that medication is put in and it will take an hour before the nurse gets around to getting to it. So one of the ways that we deal with that is we watch it, we'll remind that nurse in the sweetest way possible. We know you're busy. I just wanted to let you know that this medication is up now for our patient who's right here, and is feeling pretty sick. So oftentimes, just giving that little push helps. And so that's just one of the simple ways of advocating, making sure that you're paying attention to whether the doctor puts that dose in, whether the nurse is noticing that it's ready, and your patient's getting it. It looks like someone's having issues. Can everyone hear me okay?
Yes, we can hear you fine.
Okay, thank you. So just pay attention to that, making sure that your patients are getting their medication in a timely manner, and making sure that you're kind of sitting next to them and showing your team that you're going to be there right next to your patient until they're feeling better. And that oftentimes will kickstart everything. So that's one of the basic ways. And another thing that we've been doing to advocate for our patients is we had a situation with a patient who was brought in, admitted into the hospital for IV antibiotics. Supposed to be there for 6 weeks. We unfortunately had missed that patient coming in because she did not come in for opiate use or substance use. She was here for an infection. She was brought to inpatient, supposed to be there for 6 weeks for antibiotics, ended up leaving after a week and a half because her withdrawal symptoms were not addressed. She left the hospital, and within 45 minutes, she was brought back into the emergency room because she was found overdosed in her shower. So this is a huge thing that we look for now, and we make sure to get people that are being admitted that have opiate use disorder started on Suboxone prior to anything else, so that we can keep them there and get them healthy. We want to make sure that they don't feel the need to leave because their pain or their symptoms are not being addressed. Oftentimes the doctors, the providers will say, we can't give them anything because they're opiate use, they use opiates. We can't give them any pain meds because they're an addict or whatever the situation is. So we advocate for them by helping our providers on the inpatient side as well, making sure that our patients are being taken care of, making sure that they don't have the cravings and withdrawal symptoms that they would otherwise have if they're not started on. So those are just a couple of ways, but there are so many ways to advocate for your patients. And as you go, you'll see the different ways. Those are my simple and then the more difficult ones.
Thank you, Angela. Thank you. Next, we go to tip number 3, LaToya, normalize and educate about drug use.
Okay, so normalizing and educating about drug use is honestly one of my favorite things to do aside from just starting patients on treatment. So the particular tip and example that I have for you today is a patient who had come in. They weren't in withdrawals. They came in specifically for cravings. The provider said, we don't treat cravings. They're not having withdrawals. They don't have a CAL score above an 8. So we can't give them this medication. What if something happens to them? And so not only do I educate the patient, but I educate the provider as well. I normalize that, substance use is a natural part of, our history. Honestly, it's been going on for a long time. Even with other substances like LSD, marijuana, alcohol, and even caffeine. I very openly share that, I often display drug-seeking behaviors when it comes to caffeine, and I've noticed that I haven't had it for quite some hours. But the other thing is to educate. So I will educate on the benefits of buprenorphine and how they are used and can be beneficial for withdrawal symptoms as well as cravings. So when you have somebody coming in who has gone through the part of withdrawal symptoms and they're on the other side of that kind of cycle, they can still benefit from the medication so that they can hopefully prevent a relapse. And also normalizing that relapse happens. Relapse is a normal part of the recovery process. It doesn't have to happen, but it can. So if it does happen, the really good benefit of buprenorphine is that when they're on a stable dose, it blocks the other opioids. And then also educating about the possibility of overdose. Because when you have somebody who unfortunately is really determined to, still use a different opioid and tries to kind of overrun that Suboxone that's on the receptor, then you're going to need to make sure that they have naloxone on hand and understand how to use it. I have a nickname actually, and it really hit home when someone else made the comment about a provider feeling like they were a dealer. I have a few doctors here in our ED that call me the pusher man. And if you look it up, there's a few songs about it, but basically they say that I'm the dealer. And honestly, I kind of laugh it off. But I always tell them I'd rather be pushing this medication that is safer for them and is going to stop their withdrawal symptoms and help them feel better and allow their receptor to start healing itself so that they can get to a point in their recovery that they can do it on their own. So I'm okay that they feel the need to call me this name, even though, it's not the best name ever. But if it, I guess satisfies the stigma in their mind, so be it. But I want to always use whatever negativity they have to put a positive spin on it. The other thing about normalizing and educating on drug use is that oftentimes I have patients who feel really ashamed about their drug use and how they're using drugs. So some might be more ashamed that they're snorting or injecting versus others that are, taking pills orally, things like that. So I usually will tell patients, it honestly doesn't matter how you're using it. Excuse me. There's no better or worse way to consume any of these substances. But the important thing is that, you're here to get help and to stop so that you can start this medication and, hopefully live a different kind of productive life. So that is one of the things that I usually come across as far as, the shame that's associated with it and how I try to normalize the substance use to our patients.
Thank you so much, LaToya. Those are great tips. Great, great. Thank you very much. Next, we have Tommie. Help people through the hard scenarios.
Hello. I can't turn on my video because the host is, oh, there we go. All right. Thank you. My name is Tommie. I work at UC Davis Medical Center, Sacramento, help people through the hard scenarios. I had something this morning that I'll share with you that happened. Was a patient came in, withdrawn from opiates, had a big abscess on his arm, and it was pretty bad. So great candidate for buprenorphine. He was on Suboxone before. I called the doctors. Doctors came in and they said no. The abscess was so bad they had to admit him, and they admitted him. They're operating on him now. They're cleaning all up, fixing it up. So they had to get him on some pain medication. So the buprenorphine would have been totally out of the question. And this is just one great scenario where you think that the candidate is a perfect candidate for Suboxone, and at the end, because of the medical issues, it wasn't. So what I did was to make sure that eventually the doctor's gonna stop prescribing him this medication, right? So I don't know how long he's gonna be taking, a couple of weeks, a month, but what's gonna happen to him when he runs out of these medications? He's gonna start going into withdrawals, right? So what we did was set up a plan. I worked with the doctors and discharge planners. When he's discharged, he's gonna have a take-home 2-week prescription. That way, when the day comes where he does have to get off the pain medication, he can always go into the Suboxone. And we felt real comfortable with it because he's been on Suboxone before. And then, of course, I connect him with the clinic. And he has follow-up care with the Dr. Casper that's going to help him out. So this is a great scenario on how we all helped each other get this patient the medical need that he needed. I was afraid of him getting discharged and going home and then running out of his pain medication and coming back to the ER. So that's what I try to prevent. But thank you for listening.
Thank you so much, Tommie. That was great foresight and just great creating a team approach and sticking with the patient. I think there's a theme here is sticking by the patient. Tip number 5, Christian, be confident.
Hi, everyone. Can you all hear me? Yes? Can everyone hear me?
Yes, we can hear you. No problem.
Awesome. I'm Christian. I'm one of the navigators here at Highland Hospital in Oakland. I kind of want to speak about 2 things when it comes to confidence. One of them is going to be with providers and staff, and the other one is going to be with patients. Everyone here should understand that this position is very new and very unique, and nobody else knows how to do it. Like, you all are the experts at this stuff. So if you are not confident around staff who have no idea what they're doing when it comes to this patient population and starting treatment for patients with substance use disorder, especially in the emergency department, the staff is going to be uncomfortable. But when you walk in there and it's, having confidence just in anything, and you project that confidence to the treating team, not only will they want to help you, they'll start to trust you, and they'll start to, want to help other patients and use you as that, champion for those patients. I'll bring up one scenario where we had a patient who actually wasn't in really severe withdrawal. And we wanted to try a different type of approach to his treatment in terms of starting him on Suboxone. And the providers, here at Highland know me really well, and they asked me what I wanted to do for the patient. And, I advocated for the patient to get a really big dose all at once, based on his history and what he was telling me. And they looked at me a little sideways, like, we've never done this before. But I said it with, a little bit of authority and confidence, like, we're going to do this. I think it's going to work. I will be here with the patient the entire time. And lo and behold, it did work. And so that's one part of being confident, is walking into your department and knowing that you are actually the person that knows the most about this stuff. And the second thing about being confident is being confident in front of your patients. They are trusting you with a lot of information. They're acutely sick in front of you. And if you're confident in front of them and you show that, you're there to help them, they're going to, one, trust you to tell you stuff that's going on, but two, also, they will probably give you, as the navigator, more information that they're going to give a doctor, a nurse, a registration person. And you can ultimately start doing more for those patients because they trust you, because you're confident in what you do. And you may find some stuff out about that patient that could be unrelated to their substance use disorder, but may be really critical to their medical care, or their living situation, or their housing or food insecurity. So confidence is key. And it takes time and it's hard, but as you slowly integrate yourself into your departments and your hospital, this is something that, we all grow with, and it will really, really be a key for you as a navigator, not only just within your department, but as you grow and expand and start to teach other navigators around the state. So again, really nice to see you all. I think there are like 90 people here, so this is great, and nice to meet you all virtually if I haven't met you before.
Thank you so much, Christian. Yeah, the great tips, very good. I have nothing to add to you guys. You guys are awesome. There was a question from Azalin Sove. In that situation, what is the transition time stopping medication starting Suboxone? I'm going to tell you the reference. You need to go on to our On Shift, okay? Our On Shift website on californiabridge.org. There is different protocols. There are algorithms for buprenorphine, as well as home starts, gentle start and a rapid start. So definitely, if you want more information, that is on our website, california.org. Tools, it's in the chat. So it's a great place to get information if you need it, or to print it out and give it to your provider. Some of us are not very versed in medications, and we don't need you to be. We just know how to supply you with the resources. So you have resources for them, as well as the 24-hour warm line clinician. So again, we have plenty of resources. Is it okay to fake it till it make it in the confidence? Of course, I like that. Hey, fake it till you make it, right? Right, Sun Mentors? Have you guys done that?
Definitely fake it till you make it, but also definitely understand your boundaries and your scope and stay within your scope.
Perfect. Very well said. Any other questions? Okay. Promoting your medication for addiction treatment. We are recruiting all sons right now to promote your program. So if you haven't heard me talk before, we need you to call your hospital and become a secret shopper. Find out if your hospital operator is referring to you. what we've created, because we found we had an instance where somebody called one of our hospitals associated sites for MAT on our map on our website, and the operator at the hospital was not aware of the program or did not know what a substance use navigator is. So we've created the hospital education tool. This is a great flyer information. You can type in your name on it, and it just briefly, very briefly tells you about the medication for addiction treatment program in the emergency, your program. It describes what to do when a patient's calling for help and how to contact you. So please, please, can you download it? We will put the link in the chat momentarily. If not, I will send the resource in a follow-up email, so no worries. And again, we want you to call and see if your program, if you get the operator to transfer to you. All right, so that's one thing you can help us. Some takeaways, of course, we always love to just recap what we were doing. Harm reduction strategies will change the culture in your hospital ED. Harm reduction in the ED reduces barriers for patients and supports racial justice and equity. Remember, we work with a very vulnerable population. Some of our patients are homeless, correct? And they are victims of domestic violence, and they have dual diagnosis. So remember, you know, your program really is a lifesaver for some of our patients. Be the role model for destigmatizing language and cultural competence. Again, I, as an RM for 27 years, I didn't change my destigmatizing language until I became affiliated with California Bridge. And I share that as a testimonial that some of this stuff is new. It's new to nurses, new to doctors. And so, you know what? Sometimes I mess up. And so don't be a hard critic. For even those milestones of your staff, specifically if they are talking with stigmatizing language, just be the role model and continue and have patience. Because again, like I said, up until I became a son and affiliated with California Bridge, and that was only 2 years ago, I have to say I was not educated, and that's all your staff is. They're not educated. And educate your hospital operators about your MAT program. Promote your own program. Make sure that if you call your hospital, they would refer to the ED or you as a son. We have evaluation. We will put that in the chat. I can see that we did put the hospital tool for education and the evaluation are in the chat. So please, if not, again, I will send out an email later with the following information. You can join us on our social media. And thank you for our wonderful Sun Mentor team. I think everybody give a round of applause. I think they're amazing. They have so many great stories and knowledge. Christian, Rebecca, LaToya, Angela, Tommie, and Chaya, thank you so much for being here and representing California Bridge. If you have any questions, please don't ever hesitate to contact me or your Sun Mentor. We are here for you. We are here to support you. And we made it on time. Really, that's a challenge for us. We always have so much to say. So I really want to thank our Sun Mentor team. They really did a great time. So again, thank you. And until next time, our next training will be, I have that written down here, July 22nd. Wow, next month, strengthening community connections. We're going to be building community resources. So we will have various resources for you, including some telehealth, tribal health. So it will be very exciting. We are confirming our community resources to present to you. So will be very interesting. So we'll look forward to seeing you at our next training. Thank you.